Good evening, everyone, and thanks for joining us for tonight's webinar, Patient Education, an essential component of first-line pain management, presented for us by David Monk. My name is Liz Robinson, and I'm an Education Coordinator with the Western Primary Health Network. I'd like to start tonight with an acknowledgement of country. The Western New South Wales Primary Health Network acknowledges that we work on the traditional lands of many Aboriginal clans, tribes, and nations. I'd like to pay respect to elders past, present and emerging, and acknowledge the traditional custodians who care for this land on which we work and live. I acknowledge and respect their continuing culture and the contribution they make to the life of the communities in our region. The webinar is being recorded tonight and will be made available for viewing via a link sent to participants. At the end of the webinar, a short survey will pop up on your screen, so please take a minute to complete this for us. Hopefully on your screen you'll be able to see a toolbar up the top right-hand side of your screen. If you click on the orange arrow, then the control panel should open up to the bigger screen down the bottom there. Everyone's in listen-only mode to optimise the sound quality for everyone here tonight. So if you've got questions or comments, please use the questions box. So if you click on the little triangle next to questions, it should open up a pane. You can put your questions through there and I'll talk through those with David to answer throughout the presentation, and we'll try and have some time for questions at the end as well. Our presenter tonight is Mr. David Monk, and David's a CNC in pain management. He's been working in the pain management field since 1998, so for a long time, and completed the Master of Science in Medicine Pain Management at the University of Sydney in 2012. As well as working at the Greenwich Hospital Pain Clinic, he works as the Acute Pain Service CNC at RPA. His primary role at Greenwich Hospital Pain Clinic involves working with Dr. Amanda Johns, who's also going to present for us in a couple of weeks, to provide outreach pain management services to New South Wales Far West LHD. This service includes telehealth consultations, video link group patient-led patient education sessions, outreach site visits, and training and education for LHD and primary care clinicians to build local capacity. So thanks for presenting tonight for us, David. I'm going to hand over to David to start now.
Excellent. Thanks, everyone. I have a correction to make already. I don't have a Master of Science in Medicine. I have a Master of Medical Science because I'm not actually a doctor. But that's not Liz's fault. That was what I sent her. So that's already made me laugh a bit. So it's wonderful to be here tonight, and thanks to everyone for attending. It's what I'm going to talk to you all about tonight is how I talk to patients about chronic pain. And, I believe that it's quite essential for patients to get educated well about their condition. And it's really quite a difficult thing because it can be a bit vague. It's not well understood. And, I'm going to start by talking about the definition of pain, which in and of itself is can be a tricky thing. So if I can just make my screen go. So, the International Association for the Study of Pain has recently revised the definition. It's interesting because the original definition was generated in 1979. And that definition said that pain was an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And the new definition from this year says that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So there's not a lot of change there, but what they did do was get rid of the verbal descriptors. So instead of saying that the patient was needed to describe what was associated with actual tissue damage, it could just resemble what it was. So it really, you know, makes you think that 4 decades later, they felt it necessary to change the definition of pain, and what they felt necessary was changing the way the patient described their experience, or that the patient needed to describe that experience. So what I do, I've got issues already. I need to go to my next slide. There. So what I do to the patient with the patients is that I put up this slide and I say, you know, what is pain? And they give me some of their own descriptors, and it's usually very sensory focused. It's usually very somatically focused. You know, it's a hurt, it's a burning, it's aching, you know. And what I need the patients to understand is that it's all of that, but it's also an emotional experience. So the definition says that pain is a sensory and emotional experience, not that it's a sensory or emotional experience. It always has to be an emotional experience associated with or resembling actual or potential tissue damage. So by definition, pain is an emotion. And this often makes patients feel a bit uncomfortable because to them it's a sensation, it's a hurting, but we really need them to know that it's also an emotional experience, and that emotional experience is a negative emotional experience. It's never pleasant. By definition, it is an unpleasant emotional experience. So it's always associated with suffering, and it's always associated with fear or worry or concern. So, sorry, I'm just going to change. I'm using 2 laptops here. I'm just going to go here. So, why is it always associated with fear or anxiety? And that is because it's our body's alarm system. So pain warns us that there is a potential threat to our body. This is how we've evolved over many millions of years. And our bodies are very good at amplifying signals of nociception. I don't say nociception to the patients, but our bodies have evolved over millions of years to increase the volume of those pain signals, nervous system signals, so that we can't ignore pain. And it's very good at that. And as I said, my last point says, this is usually a good thing so that we don't get hurt. It's protective. So this is understandable. It's easy to understand that pain is amazingly good at protecting us from harm if we look at acute pain situations like sunburn. We're sunburned, we don't go out in the sun and get burnt even more. You know, we have hyperalgesia. I don't say this to the patients, but they're all good examples. Surgical wounds, you have an operation, you don't get out of bed the next day and go straight back to work. You allow healing to take place. So pain, acute pain, is an essential part of protecting us from injury and for allowing the healing process to take place. People don't walk around on fractured bones in their legs. They rest that leg until healing has occurred. And generally, the course of healing is associated with some pain. But by the time the bone in your leg is healed, the pain has subsided so that you then can get on with your life. So it serves a very useful purpose. But what about chronic pain? How is that different? So unfortunately, there's a proportion of the population where the pain doesn't subside, but persists long term, even when the healing or the medical illness or the injury appears to have finished. So why would this happen? You know, what is causing chronic pain or persistent pain? Why would pain persist after the tissues have all healed? There's a number of mechanisms, but basically what we're seeing here is a sensitization. So people have become sensitized. Their nervous system is hypersensitive, if you like. So the way I explain this to people is to say that the pain nerves are always on. Nociceptors are always humming away, but they're humming away just under that threshold that causes pain. So it only takes, it's a finely tuned system. And remember that it's been tuned over millions of years evolutionarily to protect us from damage. So we want a finely tuned system. We want a strong pain nervous system in our body, but only if it serves its purpose to warn us of actual or potential tissue damage. So the problem with many chronic pain conditions is that it's a result of a sensitized nervous system. And I love this slide because it often, patients really respond to this one particularly well, because I say to them, they're all in chronic pain, and I say, who would like their pain nervous system, the volume knob on their pain nervous system to be turned down? And they all raise their hand and say, yes. So the problem here is twofold. You've got an alarm system going off that's not recognizing any danger, and it's going off really loudly. So it's that, the alarm is broken. But, and this is the important point, is the nervous system broken? Is your body broken? Often the patients will say, yes, it's broken, we need to fix it. And I say to them that it's, pain sensitization doesn't necessarily mean that there's anything wrong with the nervous system. There's no hardware problem. It's more like a computer software problem. So we don't really need to change anything physically. In fact, if anything, we can say that the physical nervous system is working really well. It's just working too well. It needs to be reprogrammed. So we need a software, a restart, if you like. So I then go in and talk to patients about feeling pain where there isn't sign of any damage. So this can happen. So the really good example that I've come up with is thinking about phantom limb pain. And it's because everyone seems to have some concept of phantom limb pain, even if they've not experienced it or even known anyone who's suffering from phantom limb pain. Most people have heard of it. So, what is phantom limb pain? If someone has their leg chopped off and they have a lot of pain in their foot, the foot that's been amputated, can we scan that foot? Everyone, it's obvious, but it's I think it's a good example because it is so obvious. And then if we scan their leg, the stump, would we be able to see where the problem is there? No, we wouldn't. If we scanned their spine or their whole body or their brain, would we be able to see on their brain scan the pain that they're experiencing in their foot? And everyone pretty much agrees that no, that doesn't make sense. So that's how I try to get the concept through to people, that we see structure, not pain. We can see bones really well on an X-ray. We can get a CT scan that shows a lot of different structures. a lot of different densities well, and we can go so far as to get an MRI scan and have, you know, really detailed, really quite beautiful scans of, or images of inside your body, but we can't see pain. We can only see structure. The trick here, though, is to not discourage patients from getting a scan, because we need, you know, we need to exclude red flags. We do need to image a lot of patients to see what's going on in there. But the trick is that when you get a scan back that looks fine, we have to use that opportunity to encourage the patients to feel good about that. The worst thing, in my opinion, that doctors can do is scan a patient's back or arm or leg and get a you know, a good image back that shows no anatomical pathology, looks absolutely perfect, and then say to the patient, "Oh no, this is terrible. I can't see anything wrong. We're going to have to, you know, I don't know what's going on, why you've got so much pain." We need to say to these patients, "This is great news. Your x-rays come back and it's fine. Your bones look really healthy, really strong. The structures are all fine. This is great. I know that your arm's in pain, but we need to just get on with the physiotherapy, keep up the activity. There's absolutely nothing in this scan that demonstrates that there would be anything dangerous about you using this arm normally." So as you
David,
can, yeah.
sorry, just before you go on there, there's just a comment from Amanda, and she says that, can we please recognise that nociceptors are not pain nerves? This only serves to confuse patients, as it makes them think that the pain is an input into the CNS rather than an output.
Yeah. I'd like to thank Dr. Johns and Lorimer Mosley for those comments. You're absolutely right. There, you know, it's difficult because in an ideal world, I wouldn't even use the word pain nerves or nociceptors. It's all about the patient's emotions and feelings and sensations. So yeah, the activation of nociceptors is not pain. Pain only occurs, you know, in the patient's brain when they experience that, and so it only exists if the patient is reporting it, or according to the new IASP definition, if something is resembling actual or potential tissue damage. So yeah, good point that the activation of nociceptors is not pain. And I know that Lorimer Mosley uses the word alarm fibers or danger fibers, but I don't want to tell the patients, "Oh, you know, your danger fibers are firing," because I think that that's, you know, problematic. So it's hard to get across the concept of pain equals tissue damage or pain equals harm. You know, it's hard to tell the patient that that's how the body is set up in general, but you know, they shouldn't worry about that. They should just push through the pain. So what I was going to say before is that you'll notice on the bottom of this slide it says Associate Professor Stephanie Davies. So a lot of this content, or a bit of this content, I've gotten from the Fremantle Hospital Health Service with the permission of Stephanie Davies, because it was set up in 2011 for their pre-clinic education program, which we have now adopted at Royal Prince Alfred Hospital as well. So now when I show this image to the patients, it doesn't have the reference on it, but I was told I had to have references on my slides. And so when I talk to the patients, it's just the two images with the lumbar disc herniation, and they can't read that it resolved without surgery. So it's, this is obviously from New England Journal of Medicine, 2016, and it's a really good medical image that shows a 29-year-old female who presented to the spine clinic with new onset pain in her right leg. So then, I asked the patients questions about picture A, and I say, what do you think happened there? Well, first of all, I asked the patients is this image of a patient in pain? And then I'll say yes, yes. And then I have to remind them that we can't see the pain there. It's just a herniated disc. The only way we would know if this patient was in pain is by talking to the patient. And then I ask them questions like, what do you think happened? And they say, oh, she was in a car accident, or she fell off a building, or someone hit her, or there was, some major trauma. And in fact, if you read the article, the patient is as I said, a 29-year-old female who had reported back pain 6 months prior to this first image, and there was no precipitating event whatsoever. They'd actually had mild pain before that for several years. So, it's interesting how catastrophic a lot of the patients' ideas are when they see an image like this. And then we talk about image B, which obviously is, I say is the same patient 5 months later. So what happened here? And most of them say, oh, they had an operation and the surgeon fixed it. And then I say, no, they didn't. The patient elected to manage the back pain conservatively. They did have some injections into the back, epidural injections of glucocorticosteroids. And then 5 months later, the pain had gone away, and they had a follow-up X-ray, and the disc herniation had gone. So it's a very interesting case and not uncommon. And the evidence suggests that, treating these types of disc herniations conservatively is sensible. I'll stress that this patient had no bladder or bowel symptoms. They did have some paresthesia in their leg, but that resolved quite quickly. So, I think patients are often very surprised to know that if you've got back pain like this and you've got referred pain down your leg, the evidence-based practice really is to do nothing and wait for it to fix itself. And the interesting question here is what would happen if this patient presented and you immediately started the patient on opioids, or any drug therapy for that matter? 5 months later, when the pain of the herniation has subsided, would that patient know to stop the opioids, or would that patient just keep taking the opioids because they would assume that that's why their back pain has resolved, not because of natural healing process, but because of the continuation of opioid therapy? And then we talk about different types of pain. So as a general, to generalize, there's two types of pain. There's nociceptive pain and neuropathic pain. And I talk to the patients. I explain this to patients by just saying that nociceptive pain is sort of normal, common garden variety pain. If it makes sense, it's probably nociceptive pain. But neuropathic pain is anything out of the ordinary, really. But it's often associated with electrical qualities like burning or shooting, sudden shocks. lightning, stabbing. I like patients who get creative with their pain descriptors. And I had one patient who told me that I asked what their pain in their knee felt like, and they said it's like a toothache. It's exactly like a toothache, except the tooth is in my knee. So that's probably neuropathic pain as well. You know what I mean? Anything out of the ordinary. And neuropathic pain is associated, by definition, it's a pathology of your pain nerves. And so it's generally opioid resistant and, you know, needs a specific anti-neuropathic medication to treat it. But in terms of that pain being an alarm or, you know, representing actual potential tissue damage, I tell the patients that that is generally not the case. Because it's pathological by definition, it's not physiological pain. It's not protecting the patient. So it shouldn't, although I understand it can be highly unpleasant, it shouldn't stop patients from engaging in normal activity or engaging in rehabilitation activities like physiotherapy. And then I talk about how chronic pain can become a bit of a global problem, if you like, and take over your entire body. So, you know, at least 30% or more of patients who suffer from persistent pain also complain of global body pain, chronic fatigue, sleep problems, either hypersomnia or insomnia, lack of energy or motivation, you know, problems with cognitions and motivation, mood problems, particularly anxiety, and generally feeling unwell. So, you know, it's a terrible thing that can, you know, take over your entire body. And once it becomes a whole person experience, we need to deal with that holistically. So if your pain experience is affecting your general health, your quality of life, your ability to work, your relationships, you know, that's why we need a team of professionals to treat the big picture of your pain. People like psychologists, physios, OTs, social workers, and dietitians. And, you know, I'm really glad I added the dietitians because it's become the sort of sexy thing in pain management in Australia or globally for the last couple of years. But the patients often, I find, really like target that word and say, dietitians, can my diet affect, you know, my pain? And I say yes, and you know, it generates a lot of interest. And having said that, I put psychologists first, and that's often something that patients are a bit avoidant of. Because remember at the beginning of the talk, I was saying that when I was asking them what is pain, they generally have a very somatic focus, and for whatever reason are often reluctant to admit that there are psychological or emotional problems associated with their pain or preceding their pain. So,
just before we move on there, David, would it be all right if we have a bit of a poll? And this is one for everyone to answer.
Can't wait.
Your answers are anonymous, so other attendees won't be able to see what you reply. So just a question about non-pharmacological treatments of chronic pain. And you can put in more than one answer for this one. People can select any other treatments that they've recommended to patients. Got Got some votes coming through now. I'll leave it open for a few more seconds. Okay. We'll close that poll now and have a look at the results. So a lot of people have recommended or instigated patient education, lifestyle modification, exercise, and CBT. So the highest winner there, David, was patient education, 98% of the respondents. Yeah.
Excellent. Shall I carry on?
Please.
So after I talk about pain, how do I get rid of my pain being a global, experience? It's sort of a segue into the fact that at least 50% of people with chronic pain have depression or anxiety. And, it's well known, there's good evidence to show that if you have an anxiety problem in life, then you have a much greater chance of developing chronic pain. So that's, state anxiety or trait anxiety condition puts people into a high risk category for developing a chronic pain condition. And then people in chronic pain over time are at very high risk of developing psychiatric comorbidities, especially depression and anxiety. And remember way back in the first slide when I talked about the new definition of pain from the IASP compared to the old definition. Those definitions don't really, in my opinion, it would be more helpful to talk about how pain causes us to think and causes us to behave, and the fact that pain results in not only suffering but fear. No one who is in pain is not worried about it. If they are not worried about it, then it's not really an unpleasant emotional experience and it's not pain. So it really does make sense that patients who are in chronic pain develop anxiety and depression. But I often have a lot of problems with patients not being able to admit or acknowledge that. So it's almost embarrassing now, the number of slides that I go through talking about pain and depression and pain and anxiety, but I think it's really necessary. So, as I say to the patients, there's nothing as stressful as living with pain all the time. It punishes you. You become depressed, and once you become depressed, it's even harder to cope with the pain. It's a vicious cycle. Pain causes, problems with motivation, activity, and mood and sleep, and all of these things then feed into depression. So it becomes really difficult to treat both the pain and the depression. But the pain is also always associated with high levels of fear and anxiety. And that's, as I explained before, an evolutionary condition to keep us alive, to avoid tissue damage, and to stay safe. So, there's nothing more stressful than having an alarm going off in your body 24 hours a day, 7 days a week without, that's unnecessary. And we know that the same parts of the brain then, produce nervous chemicals that are associated with pain and anxiety. So it's really messes up your nervous system. And the pain and fear are linked. So, you know, what patients tend to do over time is become hypervigilant. And, you know, physios and the people use words like kinesiophobic. So they're afraid of moving. Some patients develop a fear of pain itself. So what we're really trying to address here are specific maladaptive cognitions that people with chronic pain have that we term fear avoidance and catastrophization. And we really need to talk to these patients about this, because we don't know what the patients are actually afraid of unless we ask them. So some patients may be afraid of damage, and explaining that movement is safe and adaptive for them may help a lot. Patients who are afraid of pain, we may need to specifically talk to them about how to best avoid pain. If they're not afraid of moving, they're just afraid of pain, then maybe sorting out a time of day, or a physio at Greenwich Hospital really loves heat. She likes to get patients in a hot shower, then have a hot pack, and then in a warm environment, and then that minimizes their pain, then they're happy to move. So we really need to work out what the patient's afraid of. I had a patient the other week who wouldn't leave the house because she was afraid that she would get injured, but she'd get run over by a car, or she would fall down steps, or she was just afraid of, she was catastrophizing that her pain would stop her being able to protect herself outside of the house. So we can't ignore depression, anxiety, and stress. And these are the slides that I show the patients. And it's a bit cheeky because I actually name a drug on one of my slides, which is duloxetine. And that's because it is one of my favorites, because it is an excellent anti-neuropathic drug, and it also treats depression at the anti-neuropathic dose. So if a patient is depressed and anxious and has a neuropathic component to their pain, then I think duloxetine, I've seen a lot of success through using duloxetine. But the most important point I want to make is that it's really quite almost impossible to treat chronic pain conditions if you're not treating the anxiety and depression first, or at least at the same time. And my final point says, it blocks any progress that we can make. And it's around about this time that patients, start to, open up and possibly admit that they might, that their emotional state is important in terms of their treating their pain. And I really try to normalize it by saying, often, people who are depressed don't realize that they're depressed. And then when we talk about depression and anxiety, and if we ask patients to see psychologists, generally it is for the pain psychologist to address those specific cognitions and behaviors associated with chronic pain. But it definitely doesn't mean that we think the patient's imagining it, or it's all in their head, or that they're crazy. That's again getting back to Dr. Johns' point about nociception. It's, I try to say that the pain is in your nerves, in your nervous system. I don't tell the patients that it's in their brain, even though it is, because when I say the pain is in your brain, then they think it's in my head. So a nerves or nervous system is I think the safest bet when describing where the pain is in a patient's body.
David,
so,
there's a question
yep.
just about the education sessions that you run from Letitia. So do you do these education sessions in groups or individually? Just wondering if it's a day session or over a few sessions.
Yeah, I do them in groups. And interestingly, I did try to do it over telehealth, but it was just too hard to organize a group of patients to come to, say, Broken Hill or Menindee or Wilcannia while I was in Sydney. So I tried to do 2 sessions and no one turned up, but when I travel to Broken Hill, which is 3 times a year, I do a session each day, and they run for an hour, but I talk to the patients for an hour, and then I have as much time as we need for question and answers. And even then, when I'm in Broken Hill and I've booked the YMCA wellness meeting room, I invite 30 to 35 patients so that I will get 5 to 10 patients there. And I invite their partners as well, or carers. So I get about a 30% turn-up rate. And it's a good question because I invite patients who may not have been seen in our clinic. So they're on wait lists. They may have been seen, but really the beauty of this patient education session is that it gives the patient a good idea of what the expectations are when they actually are, on the telehealth screen in front of Dr. Johns and I. So Dr. Johns and I don't have to spend our 1 hour initial consultation talking to the patient about these sort of concepts. It's really helpful. We can, just get down to the nitty-gritty of individualizing everything to this patient's experience. So we'll move on. I'm running slightly under time now, but so then I talk about physical therapy and exercises. So it's, this is all about neuroplasticity, and talking to the patients about neuroplasticity is often problematic because it's a difficult concept. But the way patients, the way a lot of the patients have gotten into a chronic pain condition is through neuroadaptation that's maladaptive, and the way we get out of it is to improve fitness and strengthen muscle groups and boost exercise, and that'll all improve mood. So I often say, that's the term "use it or lose it." And they all go, yeah, you got to lose it or you lose it. Use it or you lose it. I'd say, well, neuroplasticity is the exact opposite. You've lost it, so you've got to use it to get it back again. You've got to use it to get more. And it's all about muscle strength, fitness, and using energy to get more energy. And it's a difficult concept, but the final concept I talk about is pacing. And, I got to be honest, often I finish before pacing because pacing's like the last thing, and I often leave it off. I read the room, but pacing is a quite complicated, but it's all about not overdoing it and not getting out of that vicious cycle where you overdo that boom or bust cycle. And I'll just show you the next couple of images. Look at it. This is a typical boom and bust cycle. So that dotted line is your baseline. And if you're going, well above that, then you're crashing well under it, and then you recover, and then you have another boom cycle and then a bust cycle. And you'll notice that over time, these cycles get slower and slower and lower and lower. So there's more rest in between, and you never get up to the activities that you want to get up to. And each time you crash, you go lower and lower. And so what we want to do is reverse that curve and don't go into the flare-up boom phase, don't go into the bust phase, stay in the pacing zone. But it's a fairly difficult concept for a lot of patients to grasp, because what we have to sort of do is that yellow dotted line is your baseline. We have to find that baseline, and then staying in the pacing zone generally involves not doing more than 10% of baseline, but for a set period, and that could be like a week or a month or 3 months, but you never bust either. So if you have a bad day, you still do over 10% of your baseline, and over time you then increase that by another 10%, another 10%, and keep at it. So I'm gonna, what's the time? Maybe another 10 minutes, is that okay? No, maybe in 5 minutes. And just talk about the pharmacology. So do you remember when I said when the patients first, we talk about the definition of pain, they have a very somatic focus, and it's all about hurt and sore and ache and pain and joints and inflammation. And what they want is some sort of silver bullet. So the patients are almost always looking for some sort of pharmacological fix. And unfortunately, we don't have it. So this slide, looks at this BMJ article from 2013, and it's a really good look at a few drugs and how they don't really work, unfortunately. So, I mean, they work, but in a very small percentage of people. And it's disappointing, but what you have to do really is expect analgesic failure. So the basic 3 guiding principles are: assess the patient individually. So, if the patient has a obvious neuropathic pain, start an anti-neuropathic, but expect it not to work, and then prepare for the next step when that fails. And if it does work, then great, you don't need a next step, but your next step might be, increasing the dose or adding another anti-neuropathic drug, or stopping that anti-neuropathic drug and changing to a different class of drugs. You know what I'm saying? You just need a plan. And I'm not saying that you should encourage the patient to expect analgesic failure, because that's maximizing your nocebo effect. I'm saying that if you start a drug, you shouldn't expect it to just cure the patient, and you should plan ahead. So I've copied this box out of the article because it's it's the practical implications of high failure rates. And the most important thing here really is point number 2, and that teaches you how to assess the success. So, Dr. Johns and I never use pain scores. And when I'm working in Royal Prince Alfred Hospital in the acute pain service, I never ask the patient for a pain score. They're pretty useless. So reduction in pain scores is not our goal. It's improved sleep, improved mood, more energy, better life function, better quality of life, better ability to work. I don't really mind if the patient comes back and says, I'm still in 10 out of 10 pain, but I've been able to go back to work full time. I play with my kids every day. I exercise regularly. I'm eating well and sleeping well. I've stopped drinking alcohol and I feel great. I'm not going to say to that patient, but you're still in 10 out of 10 pain. I think we should double your drugs. That's not how it works. So the other thing about this slide is point 4, that we don't really know what to do. There's no good evidence-based practice for starting drugs, for what order to start them in, what dose to start them in. I mean, obviously, the thing that I tell patients, and I tell them, I have to tell them this because their expectations are often that they will get all of the drugs in one go at the highest dose. And I have to tell them that that's not how we work, and that we have to use that old adage, you know, start low, go slow, only do one thing at a time. Because if we put the patient on 3 drugs in one go and they have excellent analgesia, we don't really know which one of those drugs has worked, or maybe it is a combination of all of them. But basically, that patient then wants to be on those 3 drugs indefinitely. And if we put the patient on 3 drugs in one go and they get horrible side effects, we don't know which drug has caused that side effect and which drug has worked. So we have to, as I said, start low, go slow, only do one, make one change at a time. So this is also from that BMJ article. Just bring it up because I want everyone to take note that, you know, the evidence in this study showed that oxycodone at 40 milligrams, 40 to 100 milligrams a day for chronic low back pain, a 100% failure rate. So if oxycodone causes a 100% failure rate in chronic low back pain, the opioids don't really work, why do the patients keep taking them? And remember way back 20 minutes ago or more, when we were looking at that New England Journal of Medicine image with the 29-year-old whose herniated disc resolved on its own in 5 months. And I posed the question, if that patient had been started on opioids, would they still be taking them? I think my answer is probably they still would. And the reason is that they can be difficult to get off. And so I show patients this picture. And I didn't mean to at the start. I just had a patient one day who said, who was really interested in where the opiates worked and what they did when they went into your body. So I had this article on my computer and I brought it up and I said to the patients, these red blobs are, you know, high concentrations of mu opioid receptors in your brain and brainstem. And they were all fascinated. And one of the other patients actually said, oh, look at that brainstem. It's like all over the brainstem and it says breathing. No wonder people stop breathing when they overdose on opioids. I'm like, yes. And but the main point is that, you know, the concentrations of mu receptors in the brain, you know, also include the ventral tegmental area and the nucleus accumbens. So, you know, densely concentrated in brain regions that are associated with reward and underlie perceptions of pleasure and well-being. So this explains why medications like opioids produce both analgesia and euphoria. So if pain is an unpleasant sensory and emotional experience, you know, opioids not only directly activate brain analgesia and reward regions, but also mediate, you know, learned associations between taking a drug and feeling good. It's a type of Pavlovian conditioning. So over time, patients, you know, develop an association between the drug effect and the desire for relief. So it's hard over time to work out if that's analgesic or pleasurable. So the problem is that patients develop a tolerance for opioids quite quickly. So if their pain persists, even if it's decreasing, they will need more opioid to get the same effect. But over time, because of this learned association, even mild pain can trigger a response for the patient to seek opioids for relief. And so you can develop an inappropriate use of opioids quite rapidly, unfortunately. You know, we've run out of time, so I won't even talk about things like opioid-induced hyperalgesia. But I will say that in 2 weeks' time, Dr. Amanda Johns is presenting a webinar where she will talk about pharmacological management of pain. So I would encourage you to join that one. And if you go to the ACI website, there's quite a good section on general recommendations for opioid management. And the short answer for how do I wean opioids is, as quickly as the patient wants to. And it really is about patient motivation. So if they want to do it quickly, I would let them do it quickly. But, Dr. Johns and I generally, as a general rule, go to the second point, a slower wean equals 10% a month. And we say to the patients, if we wean by 10% a month, then in a year from now, we expect you to be, hopefully, off all your opioids, because that's, you're on 100 milligrams a day now, we go 90, 80, 70, and you can have 2 months off, 10% a month for 12 months, that gives you 2 months where, I have patients in Broken Hill who call me in the middle of winter and they say, oh, I don't want to wean my opioids this month because it's too cold. And then I had the same patient 6 months later call me and say, oh, can I not wean my opioids this month because it's too hot? And I said, yes, that's fine. You can, it's really up to let the patient guide you. But from what I said before about how it's incredibly easy for patients to develop an inappropriate use of opioids, and that how much opioid tolerance messes with the therapy, don't go up. If the patient says, I don't want to go down this month, that's fine. But when the patient comes to you and says, I'm really stressed and things are happening in my life, I'm on 50 milligrams now, can I go back to 60 milligrams for a month? I would encourage people to say, no, let's just stay at 50. You can stay at 50 for as long as you need to, but we won't go back up. You've coped, up to this point, let's stay there. Okay, I think I'm finished. Yes.
All right. If anyone has any questions, can you put them in the questions box now for David? We just might run one more poll while people are putting questions in.
I've left 1 minute for questions.
So I'm going to put another poll up now. This is for our medical attendees to answer. Give it a few more seconds there.
That's a good question, Liz.
Tough question, yeah. Okay. We'll close that off now. Let's have a look at the results. So it looks like most people are always thinking ahead, planning ahead there to wean and cease, but not always. Any questions there for David? If not, we'll finish up. All right. All right, everybody, thank you for coming tonight. And please, there will be a evaluation survey that pops up on your screen when we finish the webinar tonight. It'll also be sent out in an email tomorrow. Oh, I'm just getting a question through there. Oh, no, that's okay. It's a comment more than a question, I think. So thank you very much, David, for presenting for us tonight. Thanks, everyone, for coming.
Pleasure.
And please
Thank you.
complete an evaluation for us. Thank you, David. Have a good
Okay.
night, everyone.